We can start. Dr. Binta.
Hello, I'm Binta Sako, and welcome to the WHO Africa Media Briefing, which is taking place in collaboration with APO Group. First, some housekeeping. You can choose to listen to the press conference in French or in English by turning to the globe on the bottom right of the screen and selecting the language of your choice. En français, vous pouvez donc choisir la langue de votre choix en cliquant sur le bouton à droite de votre écran et vous sélectionnez la langue que vous préférez, le français. Joining us from Brazzaville, Congo is Dr. Abdul Salam Gay, Director for Regional Emergency Preparedness and Response at the WHO Regional Office for Africa. I will now let Dr. Gay introduce our other panelists. Thank you. Over to you, Dr. Gay.
Good morning and good afternoon to all the journalists joining this press briefing on the COVID-19 pandemic in Africa. I'm very pleased to be joined by this conversation by my friend, Professor Plastit Mbala, Head of Epidemiology Department and Head of the Genomic Pathogen Laboratory of the National Institute of Biomedical Research in the Democratic Republic of Congo. I'm also delighted to be joined by Dr. Kerrigan McCarthy, specialist pathologist at the National Institute for Communicable Disease in South Africa. Welcome, colleague. So far, Africa has reported 11.7 million cases and around 253,000 deaths. The continent recorded over 52,000 cases in the week ending on May the 8th, a rise of 38% from the week before. The increase is largely driven by a spike in Southern Africa, which accounted for 87% of the continent's recorded cases. This uptick has broken a 2-month-long decline in recorded infection. The increase in Southern Africa is in turn driven by surge in South Africa, where weekly recorded cases have quadrupled in the past 3 weeks. Eswatini and Namibia have also recorded an increase in cases, with both reported 50% more new cases in the past 2 weeks compared to the previous 2 weeks. Deaths have not climbed as quickly. South Africa recorded 376 deaths in the past 3 weeks, twice as many compared with the previous 3 weeks. Africa's past 4 pandemic waves have occurred around mid and end year and mostly driven by new COVID-19 variants. The winter season and high population movement during the holidays, for example, in 2021, the Delta full mid-year surge began around May and the late November with the emergency of Omicron. The current surge is being fueled by Omicron variant and relaxed public health and social measures. Since the beginning of April, South Africa alone has recorded more than 1,300 cases of the Omicron subvariant BA2 and over 700 cases of subvariant BA4. It also recorded more than 200 cases of subvariant BA5. Just note that these numbers are related to the cases that are sequenced, and the increase in case is in an early warning sign that WHO is closely monitoring. We urge countries to step up preparedness and ensure that they mount an effective response in the event of the fresh pandemic wave. Over the past 2 years, African countries have greatly improved their COVID-19 response and strengthened surveillance, testing, and treatment. The continent has ramped up genomic sequencing. Between January and April 2021, African laboratory reported about 9,000 sequences. This has raised over 4 times the nearly 40,000 over the same period this year. It is vital that these measures are maintained and quickly scale up should COVID-19 cases surge further and wider. Meanwhile, as WHO in Africa, we continue to support countries to keep the momentum of COVID-19 vaccination going. While almost 500 million vaccines have been administered in Africa to date, only 17.3% of the population is fully vaccinated. To continue to drive these numbers up, we must mount a response against the low-risk perception of COVID-19 as cases and deaths decline, and reiterate the need for vaccination in the face of easing and public health measures. There is need to be major push to encourage everyone that has had at least one dose of a COVID-19 vaccine to complete their primary series and vaccination in people in high priority group to get a booster dose. The past few weeks show that now is not the time for complacency. To beat this pandemic, we must stay vigilant. I look forward to our discussion today, and thank you for joining us.
Thank you, Dr. Gay, for this wonderful overview. Professor Placide Mbala, could you tell us how the DRC's National Institute for Biomedical Research has supported the COVID-19 response?
Merci en tout cas. Merci pour la parole. Je pense que l'INRB, l'Institut national de recherche biomédicale, joue un rôle important en termes de surveillance, donc de réponse à la pandémie de Covid-19, grâce à ces structures qui ont été mises en place, coordonnées directement par le professeur Mouyembe, et aussi grâce à son laboratoire, et qui a été assigné par OMS et Africa CDC comme hub qui supporte les autres pays de la sous-région, notamment la République du Congo, le Tchad, la RCA, donc la République centrafricaine, et également le Cameroun. Et donc, dans ce cadre, nous faisons les séquençages pour pouvoir rechercher les différents variants de SARS-CoV-2 dans les échantillons de la République démocratique du Congo, mais aussi dans les échantillons qui nous viennent des autres pays collaborateurs de la sous-région. Et ainsi, par exemple, pour la RDC, nous avons vu défiler les différentes vagues où nous avons vu l'introduction du variant alpha et bêta vers novembre et décembre 2020 et l'introduction du variant delta vers le mois de mai-juin 2021 et l'introduction du variant Omicron vers, je crois, novembre et décembre 2021. Et au début, nous avons eu le sous-variant Omicron BA1 qui était prédominant par rapport au BA2, mais vers janvier et février, mars 2022, il y a eu un shift où il y a eu une prévalence un peu plus élevée du sous-variant Omicron BA2. Et en mai, juste récemment, avec les quelques 13 échantillons que nous avons analysés, nous avons une introduction, donc 2 cas du variant BA.
Apologies, there's a problem with the connection. We'll wait until he perhaps comes back. A bit of patience, please.
Allô?
À vous.
Est-ce que vous me suivez?
Retour, professeur.
Oui.
Allez-y.
Oui, donc désolé. Donc là, voilà, donc ce qui fait que avec le variant Omicron, donc on a récemment, donc en mai, avec les 13 échantillons que nous avons déjà analysés pour le mois de mai, grâce à notre plateforme de séquençage, donc on peut identifier 2 cas du variant BA4 et un cas du variant BA5. Donc, c'est cette introduction que nous remarquons au mois de mai. Et ce que nous remarquons aussi Après cette baisse que nous avons enregistrée de cas depuis pratiquement le mois de janvier 2022, nous observons une augmentation des cas dans la province de Lualaba, et c'est en discutant avec les collègues de la province de Lualaba, c'est certainement dû au fait qu'il y a des mining, de compagnies de mining dans cette province, et où il y a plusieurs travailleurs qui viennent de la Chine et de l'Afrique australe. Et donc, probablement, et ce qu'ils remarquent aussi, c'est que régulièrement, lorsqu'il y a des flambées, soit en Chine, soit en Afrique australe, il y a également un début de flambée dans cette province qui, par après, peut également entraîner une propagation dans les autres provinces du pays. Donc, voilà ce que je peux dire par rapport à la situation de Covid et aussi à notre implication à la réponse de Covid en RDC.
Merci beaucoup, professeur. I would now like to turn to Dr. Kerrigan McCarthy. Could we know more about environmental surveillance and why this is important for tracking COVID-19? Dr. Kerrigan?
Yes, thank you for the opportunity to share some of the National Institute for Communicable Diseases in Johannesburg, South Africa, to share a bit of our program on environmental surveillance. So environmental surveillance has a long history. It was done for cholera and typhoid and more recently polio. Environmental surveillance in the case of polio, for example, is used to complement rather than replace public health surveillance based on individual diagnostic tests. And the same is true for SARS-CoV-2. So by sampling wastewater or freestanding river water where populations are unsewered, it's possible to measure through quantification and PCR-based techniques the amount of SARS-CoV-2 in the wastewater. And there are many advantages to this. It allows us to understand the dynamics of SARS-CoV-2 epidemiology at a population level without necessarily testing individuals. It also allows us to understand the broad strokes of the burden of disease in a defined geographical area. So one can look at trends and changes in the levels in the wastewater, and this has shown good correlation with the number of cases that are excreting into the wastewater. It's also relatively efficient and cost-saving when compared with testing individuals. And this is particularly useful when individual testing, PCR, is not widely available, either through remoteness or through cost and socioeconomic considerations. The testing of environmental samples is applicable both to sewered and unsewered sites. So one can test the influent wastewater into a wastewater treatment plant, or one can test river water or open drains for SARS-CoV-2. And then the last reason why environmental surveillance is helpful is that one can also detect the genetic sequences of SARS-CoV-2, and these have shown good correlation with the clinical sequences in wastewater. And there's probably a good reason to believe that wastewater sequencing may be more representative than variants from individual patient samples because one captures the entire population's worth of RNA sequences. So just briefly, South Africa has participated in the WHO environmental surveillance programs for polio, which we started in 2018 and 2019. And we subsequently built on this program when we initiated wastewater testing of SARS-CoV-2. So we had program efficiencies, and we were able to utilize the structures and the connections with the various wastewater treatment authorities to harness the system for testing SARS-CoV-2 in wastewater. And we've had some good successes. We had just started at the beginning of our second wave, and we noticed that the high wastewater levels correlated with high patient levels of burden of disease in around December 2020, January 2021. But we were then able to predict the third wave due to Delta And then the fourth wave due to Omicron, when levels started rising 3 to 4 weeks before the clinical case levels increased. And now, as we've entered the fifth wave, we've been able, as we have with the other waves, to identify the Omicron variant and the BA.4/5 variant in wastewater. That's, I hope, a response to your question. We'd be happy to take questions going forward.
Thank you very much, Dr. McCarthy. Yes, indeed, you have answered the question. It's a brilliant explanation of the importance of environmental surveillance and the way you've applied it in South Africa. And now we turn to Dr. Mori Keita, the WHO Incident Manager for the ongoing Ebola outbreak. Over to you, Dr. Keita, for an update.
Thank you so much, Dr. Binta. Thank you. So, as a brief update, just to mention that the trend of the ongoing Ebola virus disease epidemic in the DRC is relatively encouraging. In fact, since the declaration of the epidemic on 23rd April 2022, we have had a total of 3 confirmed cases. Unfortunately, all of them have died. The last confirmed case was reported on 4th of May, which means that we have gone 7 consecutive days without a single confirmed case. However, about 480 contacts are still being monitored. Of this, about 200 will complete their 21 days follow-up period today. All the response pillars are now operational on the ground, and we have vaccine and specific drugs for confirmed cases. At-risk and vulnerable zone around Manaka are also being reinforced. So I would say that we are responding properly to this outbreak. Over to you.
Thank you very much, Dr. Keita, for these updates. Now that we've heard from all our brilliant speakers, it's time that we turn to the questions. And to do this, you have the Q&A, the question and answer function on the Zoom application. Please remember that you'll need to provide the name and the name of your organization in order for your question to be asked. And to answer questions, we also have 3 additional experts at hand. We have Dr. Cherno Balde, the Regional COVID-19 Incident Manager, Dr. Nixi Gumede Mwenetsi, Regional Virologist, and Zora Machikangamo. Sorry, no, Zora, Communications Officer for Vaccine Preventable Diseases in the Eastern and Southern Africa region. Now we'll begin with the questions. We have a first question from Dr. Mori Keita, for Dr. Mori Keita. The question is, have you noticed Ebola cases in DRC presenting with COVID symptoms? And if so, what was the case fatality ratio? This is from Aisa Tussar from MRCG at London School of Hygiene and Tropical Medicine. Over to you, Dr. Mori Keita.
Yeah, thank you so much. So as I mentioned, I think we reported so far 3 confirmed cases, and unfortunately, all of them have died. So we have a case fatality rate equal to 100%. So, but compared to COVID-19, I think we are not in the same figure. So just to say that Ebola is different from COVID-19, yes, even in the DRC, I think the country is responding to these 2 epidemics.
Thank you very much, Dr. Keita. I have a second question from John Eligon, the New York Times. The Aspen vaccine manufacturing plant in South Africa said it would be forced to close in 6 weeks after receiving 0 orders for its locally manufactured Aspenovac vaccine, licensed and identical to the Johnson & Johnson vaccine, and made specifically for the African market. The WHO has advocated local manufacture for vaccines as a solution to unequal access to vaccines in Africa, yet this project that was celebrated as a landmark is about to fail. What, if anything, did the WHO do to advocate for orders for this local plant? And why have those efforts not worked? If the South African plant closes, what does that mean for the vaccine manufacturing capacity on the continent? Over to you. Dr. Gay, would you like to take the question?
Thank you very much. It is unfortunate that this plant did not receive enough order, and it is for financial reason, if investment is not receiving orders, that they may have to close. This is due to the context that COVAX, which is the primary organization to order, has enough vaccine in Africa, and the most important part now is how to help those vaccines to arrive to the last mile and to be implemented to patients. Now, is it a failure? I don't believe so. And it is an opportunity that South Africa and people who work on it was in all the steps, and to have demonstrated that it was possible to produce good vaccine in South Africa. And also it has proven that these issues that was raised in many occasions in terms of scientific capacity research are possible in Africa. Now, on the other side, on the finance side, it may be a failure, but we will learn from it for the next step. And also, if we want to reinstall it in the future because of need, I'm sure that it's going to take less time. Over.
Thank you very much. Now I have a question from Lee Menglin from National Business Daily. As the more infectious BA4 and BA5 subvariants are spreading in South Africa, what are the medical and public health measures needed to combat a new wave? Over to you, Dr. McCarthy. We can begin with Dr. McCarthy.
Yes, thank you. So in terms of the medical and public health measures, I will answer a related question first from Thomas Nugent, who is requesting a question, may the new variant BA.4 and 5 cause another COVID wave in South Africa? So our Ministry of Health did in fact declare another wave. Although we must say from an epidemiological perspective, this is really an artifact of a number of parameters, which include the number of cases that have been diagnosed, the number of cases, the proportion testing positive, the wastewater levels, the hospital admissions and the deaths. Of course, we know these indicators lag. And what we've noticed is that fewer cases test positive. Fewer cases or persons are undergoing testing, and so the number of positive cases is less and less representative of whether or not there is a wave. The other artifactual problem is the designation of a variant versus a subvariant, and whether one needs a new wave to declare a new variant to declare a new wave. The bottom line is that the wastewater levels are showing an increase in the population burden of SARS-CoV-2, and that there is a breakthrough of neutralizing antibodies, which has been shown in the laboratory at the National Institute for Communicable Diseases. This suggests that, in fact, that persons who've had prior infection or vaccination may still be vulnerable to the new variant BA.4 and BA.5, although we trust that the T-cell immunity may prevent severe disease as it has done with other variants. So to answer the question, what are the medical and public health measures? These remain at present in South Africa unchanged from previous surges or resurgences in the SARS-CoV-2 that we've experienced. So essentially, the advice that our Public Health Institute, the National Institute for Communicable Diseases, is giving is to observe social distancing, to wear masks, and most importantly, to receive a vaccine. The medical management of patients remains unchanged, and we have not authorized the use of any of the newer and newly registered antiviral agents for the treatment of SARS-CoV-2. However, we are in the process of politically loosening and decreasing the stringency with which these public health measures are held. And this is primarily for economic reasons and not necessarily for medical or public health reasons. Thank you.
Thank you very much, Dr. McCarthy. We now have a live question. This is from Paul. Paul, can you ask your question? Are you logged on?
Yes, I'm
Go ahead.
here. Thank you very much. I have a rather unique line of questioning that I think the various panelists and WHO observers can answer. So last week at the Geneva Health Forum, it became obvious that the medical health-focused sectors seems to be lagging behind regarding what they are doing to really accelerate some of the climate change actions. For instance, we have initiatives such as targeting reducing medical waste, ambitious goals towards ending some single-use options. So I'd like to know what is really being done, especially in the African continent and from the respective partnering organizations that are also climate friendly, to ensure that Africa's health landscape is also catching up regarding reducing medical waste and also reducing some of the environment impact that could affect the climate change, such that while keeping people healthy, the continent is not also, the health sector is not also contributing negatively to the environment. So that is the general question. I don't know if I can have anybody to respond on that. Thank you.
Thank you very much. It's a general question indeed. Can I ask Dr. Gay to begin? You are muted, Dr. Gay. You're muted.
Okay. The environmental, can somebody help me here?
We can hear you, Doctor.
Yeah, it is still muted.
You're unmuted, we can hear you.
Okay, you can hear me now.
Yes.
Okay, thank you very much. And the question was about reducing medical waste. And a lot of work are being done, actually, particularly on the emergency that I know about the operation support and logistic in general. That start with a good surveillance and epidemiology to have a better understanding of what are the expectations and being able to do excellent forecasting. So it is the medical product that we need that are arriving on the right place when we need them, would help reduce the self-life and also help us getting in touch with the rest of the network. We know that our capacity in medical supply in WHO are mostly in the global site at Dubai, but we are on the process of developing capacities in Nairobi, Dakar, and partially in South Africa in a way that we're going to have a better network. And the other side, we are working also with member states to help them develop their capacity on supply chain system, which will help them do the same in terms of forecasting and in terms of use, and also in terms of moving the drugs that are close to expiry to other sites where they can be used properly. And sometimes it is cost saving to move a drug than to be able to dispose of it because of all the requirements that are needed in order to dispose of an expired drug. At the end use also, it may happen that we can save there and reduce the medical waste where people may be buying some doses that are more than what they need, or they start the treatment and do not finish it. All those are some community activities, and there is some NGOs that are working well on that, and we are looking forward working with them in order to support them in terms of designing their project and in terms of resource mobilization, implementation, and monitoring those projects. Thank you very much.
Thank you very much. Thank you very much. And I think I saw a hand raised by Dr. Chanobalde. Maybe he would like to add something to this response.
Yes, absolutely. I think just more on the operational level. I mean, there are also a lot of efforts, I think, Paul, which are made in terms of infection and prevention control measures, you know, in all of the different health facilities to have really a proper, I mean, a management of the waste, of the medical waste and also the non-medical waste. So there are a lot of action which are currently ongoing in all of our member state countries and in some specific countries like in Ethiopia, where we've been able really to implement very effectively, you know, IPC intervention and measures, you know, for reducing, I mean, the waste and to improve the management of waste. And you also heard about this collaboration that we are having for improving the surveillance by using, I mean, some of these environmental studies. So, I mean, the paradigm is there, I mean, really to try to intervene and to collaborate with different disciplines, you know, to have a more holistic, a more comprehensive approach, you know, while handling those health issues. So definitely, I think the approach and the paradigm is here. We are implementing some of them at different levels, definitely at the operational level. And as Dr. Salava mentioned, also the other dimensions, you know, on the operational support capacities to ensure that we have really good timeline, I mean, for the drugs that we are having, all of the other medical materials and devices, and to have a better management of these elements. Thank you, Binta, and back to you.
Thank you. We have another live question, which is from Ashvin Barting from the Observer Times. Yes, Observer Times. Are you ready, Ashvin? Would you like to take the floor and ask your question, please?
Thank you for considering my question. My question is, how much WHO Africa have understand about virus host dynamic, which is important in development of safe and efficacious vaccine? Thank you.
Thank you. Dr. Gay, again?
I did not hear well the last part of the question. Virus, I heard only.
Yes, I'll ask Ashvin, please, could you repeat your question? We couldn't hear you very well.
Yeah, sure, definitely. How much the WHO Africa scientists have understood about the virus host dynamic, which is important in development of safe and efficacious vaccine? Thank you.
Thank you. How much do the WHO scientists understand the virus to be able to develop a vaccine? Over to you.
Virus host dynamic.
I still don't think I understand well the question, but if it is the virus dynamic and the virus mutation, it is related to genomic sequence or also all the other parameters that help on developing vaccine. For genomic surveillance and genomic sequencing, we have a lot of projects that are working actually in Africa, including the Africa CDC project with Gate Foundation that has put in place a network in collaboration with WHO, and also the Center of Excellence of WHO that we have 3 hubs, one in southern part of Africa, another one in eastern and central part of Africa, and the last one in the western part of Africa, where the genomic of the virus that are in Africa are being sequenced and shared with GZ. Actually, when you compare the last 3 months compared to the last 3 months at the same period a year ago, we have multiplied by 5 our capacity on genomic surveillance and having additional information on the virus dynamic. All those are not enough if also we have not a good surveillance on the immunity response of individuals who are receiving the vaccine, because when you receive the vaccine, the booster and the following doses may be related to the immunity of the body. And it is also in the same in the rest of the world. A lot of studies are being done. So far, we know that one vaccine is already protecting against the severe cases and death. When you have the second vaccine, it is a lot better, and it is recommended by WHO so far. And the third vaccine is recommended for population that are at risk and vulnerable. And that is based on our clinical and epidemiologic data, and the biomolecular data are less present in Africa. I don't know if it answers the question, and I have our colleague also Nixie, who is connected, if she can add anything related to the virus dynamic. Over.
Thank you so much. Yes, I'm trying to put my video on. Thank you so much, Dr. Gay. And to the question as well, we know that as far as the virus is concerned here that we are dealing with, it has shown to be rapidly replicating all the time, of which is expected because all the viruses, we move on, they keep on changing all the time. But understanding that as WHO, that's the reason why that we are collaborating very strongly with most of the specialized laboratories within the continent. And as such, at the beginning, we created the very first network of laboratories for COVID sequencing and other emerging pathogens to work and study the COVID virus and the SARS-CoV-2 virus in detail so that we can understand when it comes back what is going to be happening to it. As you can see now, we are even no longer talking about the original SARS-CoV-2 virus itself, but we are more talking about the different variants that has been coming after the mutation of the original virus. And then this variant they're even further mutating themselves. That is why today we are talking about different sublineages that has been reported from different variants that has been sort of like reported earlier on during the pandemic. So as far as the study of the virus is concerned that we're talking about here, it's going to be a work that is ongoing all the time. So the scientists are sort of like working tirelessly to understand even more of what is happening with the virus. And I think Dr. Kerrigan earlier on also mentioned what is happening with some other additional techniques that we are sort of like as WHO looking forward to introduce or to establish in the entire continent so that we'll be able to know what is circulating, what is silently circulating that has not been reported using our clinical sort of like activities that can be identified by using the environmental surveillance activity. Thank you.
Thank you very much, Dr. Nixie. And here I have another question from Alex Winning with Reuters. The question is addressed to Dr. Keita. Could Dr. Keita elaborate a bit on his comment that the trend in the DRC regarding the Ebola outbreak is encouraging? Is Dr. Keita referring to the amount of vaccination that has been done so far, or are there signs this outbreak is being contained? That's the question. Thank you. Over to you, Dr. Keita.
Thank you so much for this question. So when I said that the trend is encouraging, you know, it's compared to the previous one. So now we're reporting 3 confirmed cases over 2 or 3 weeks. for instance, in the DRC, in the Eastern DRC, in Beni and Butembo, we were reporting, 20 or 15 confirmed cases per day. So, we were able, of course, to stop this outbreak. So when we compare these outbreaks, I can say that this is we are an opportunity windows here in Mbandaka to quickly control this outbreak. So now we have all our team in place. We have vaccine and we have also therapeutics, specific drugs for Ebola cases. That's why I'm saying that, of course, it's encouraging. So I don't know. I can't say that we will not have any confirmed case in the upcoming days. It could be possible because we have all some 200 contacts, in the critical phase of their follow-up period. So maybe we will have some cases. It's possible, but even if this happen, I think we'll be able to quickly vaccinate around these cases, to list the contact and to take care with the confirmed cases and to quickly stop these outbreaks. So that's why I'm a little bit confident that the situation is encouraging. Over.
Thank you very much, Dr. Keita. I have another question from Aisa Tussar. She's from MRCG, and it's regarding surveillance. So regarding mortality surveillance, such as reporting and monitoring the number of COVID-19 deaths, is there a framework that is applicable across countries to enhance reporting, since not all deaths occur in the hospital or present with a death certificate, particularly those that may have died of asymptomatic COVID or COVID comorbidity? The question is first for Dr. Cherno. Over to you, Dr. Cherno.
Thank you very much, Binta, and I can start, and probably Dr. Gay also might be able maybe to complement. I think the issue about this excess of mortality, or maybe the reporting of the COVID-19 mortality, is quite a complex question. About 2 or 3 weeks ago, there was a publication by the World Health Organization about the estimate, or maybe the underestimate of the death on COVID-19. So we saw the complexity of this question. So it's really difficult to say that there is one single framework, which can allow us, to do those assessment and understanding, because it's really context, it's really context related. In each of the country, we have different dimension, we have different context, we have different environment. And what we have seen overall, in Africa, obviously, is the quite very low number of deaths which has been reported over the pandemic. Both in the health facilities, but outside also of health facilities. Now, the question obviously that we need to ask is the other deaths which are indirectly linked to the COVID-19 because of the limited, other services, health services, which might have been offered, to other people who are not probably, who are not suffering of COVID-19. So I think those are the complex equation on which we might need definitely to continue working to have this better understanding. But at least at first glance, we can have definitely with a certain level of confidence about, the low level of deaths here in Africa, despite obviously some of the limitation of our information systems on which also we are really currently working. So that's the remark, but as way forward, definitely all of the work that we are undertaking in the regional level here for improving the health information system to be able to track both the cases and also the death, associated to the COVID-19 is really ongoing within WHO in support to our member state and in a very close partnership with our other partners such as the Africa CDC and other organizations. Thank you, and back to you, Binta.
Thank you. Dr. Gay, would you like to add?
General methodology comment in terms of excess mortality framework. It is at the global level where WHO different departments, including the emergency department, the data and analytic department, but also the UN DESA, which is in charge of population statistics for the UN in general, come up with a methodology to estimate the excess mortality in overall. And the excess mortality is based on the principle that when there is a disease like COVID-19, there is the mortality that are directly related to that disease, whether it is reported or not, it can be estimated. The second is that the health system was overwhelmed by COVID-19 in a period that was noticeable. And it has been the responsible of excess death because people did not have access to the care they needed at the time they needed it. And also it took into account another negative part in terms of mortality, which is some death that was averted by the pandemic. Because of a lack of transport and interaction, some infectious disease may have been reduced, but also some injury and accident may have been reduced that are all negative in terms of mortality. There is a methodology to put all those together into a modeling that is very complex, but the methodology that is most dominant that was used is related to the poison modeling. And the methodology is well described in our website. And it come up that about 15 million deaths happened in 24 months between January 1st to 2020 and December 31st, 2021. And that excess mortality was published for other countries. It was done in consultation with all the countries and different interaction between working groups in order to come up with this number. Unfortunately, in Africa, most of the countries do not have a death registry and all the methodologies that are necessary to count about the death. So what we did in Africa was to use the countries that have information as a proxy to countries who do not have information, and also to use some statistical model in order to complement the missing data, which means that the estimate may not be as precise in some African country than it is in other countries developed that have better methodology of counting death. So that was in general what happened for the excess mortality. Thank you.
Thank you very much for this very comprehensive response. Now we have another question from Emery from the BBC around the situation in DRC. So it's two questions. First is, correct me if I'm wrong, but a statement from the WHO indicated that this outbreak risks expanding outside the city of Mbandaka. Could we know more on the reasons why and if that risk is still a concern now? The second question is, since the DRC is a reservoir of Ebola, should bush meat consumption be prohibited to avoid the chain of transmission from animal to human? Or what should people's attitude be towards eating bush meat? I'll request first Dr. Mori and then Dr. Mbala, Professor Mbala. Over to you, Dr. Mori Keita.
Yeah, thank you so much. So regarding the first question, of course, the first rapid risk assessment conducted by WHO concluded that the risk is high at national level, moderate at the regional level, and low at the global level. So this assessment took into account the fact that the city of Mbandaka is located in the Congo River and has both road and river links to the capital city, Kinshasa, the Republic of Congo, and the Central African Republic. So I think that this is still in place. This assessment is still up to date because it's too early to say that there is no longer any risk as the epidemic is ongoing and the source of the contamination has not yet been clearly identified. This is my answer to the first question. So regarding the second question, of course, Professor Placide, my friend, can complement me later. So it's important first to point out that some physical agent can eradicate Ebola virus, such as heat, sunlight, etc. So, for example, heating to 60 degree for 60 minutes or 80 degrees for 30 minutes can eradicate the Ebola virus. This means that the problem is not the consumption of the bushmeat, but the condition in which it's prepared. Personally, I think message should certainly focus on just evidence. It's very difficult, from my personal point of view, it's very difficult to prevent community from eating bushmeat without offering them an alternative. I think we need to establish or strengthen, One Health platform at the community level that will be in charge of risk communication and community-based surveillance in this area. Yes, over to Professor Placide, maybe to complement on that question. Over to you.
Je n'ai pas beaucoup d'éléments à compléter sur ce que Dr Keïta a dit tout à l'heure. Ce que je pourrais dire, c'est que oui, comme vous pouvez le voir, c'est pratiquement la 6e fois qu'il y a une épidémie d'Ebola dans cette région, et c'est pratiquement dans la grande région d'Équateur que la première fois on a identifié ces virus, et 6 fois de suite depuis l'identification de ce virus, il y a épidémie dans cette région, et ces 6 épidémies sont essentiellement des passages du réservoir à l'hôte, ce qui donne beaucoup de matière à réfléchir, parce que auparavant, ces épidémies étaient assez espacées. Là, depuis 2018, 2020 et 2022, c'est presque tous les 2 ans qu'il y a cette épidémie, c'est qui suggère aussi un rapprochement, si je peux dire ainsi, de l'hôte et du réservoir. Donc, il y a un contact beaucoup plus fréquent, probablement, de l'hôte et du réservoir, et ce qui peut engendrer ces différentes épidémies qui deviennent de plus en plus fréquentes. Donc, c'est important, en addition à ce que Dr Keïta a dit, et de continuer les études que nous sommes en train de faire dans la faune, pour pouvoir rechercher, identifier effectivement le réservoir de ce virus. Ceci permettra au fait de pouvoir mieux prévenir ces spillovers dans le futur. Voilà.
Merci beaucoup à tous les deux. Thank you very much. Now we have another live question from John Eligon. John, could you please take the floor?
Yes, please. Sorry, two questions, one for Dr. Guy and one for Dr. McCarthy. Dr. Guy, just a follow-up on the question about the Aspen plans, because I don't think I heard this in the response, but did the WHO take any steps to try to advocate for organizations to purchase from the Aspen plans? And if there were steps taken, what were those steps? And if not, why is it, do you think, that no one has put any orders at that plant specifically? Because obviously people are still, or organizations are still ordering vaccines, but why not from that plant? And for Dr. McCarthy, you had mentioned that, the loosening of some restrictions in South Africa. You said that these are, quote, primarily for economic reasons and not necessarily for medical or public health reasons. Is that concerning at all in terms of what that might mean for, this next wave and what the consequences of that could be? Thank you.
Dr. Gay, please. The question was for you.
The Aspen plan is producing a vaccine and came very late in the process. Most of the countries outside of Africa, it was not expected for them to be ordering in South Africa because they already have a natural way of getting the vaccine they need. In Africa, mostly 2/3 of the vaccine that we received was ordered through COVAX. And COVAX, the supply chain was done by Gavi. And Gavi's authority has already said that they did not plan to order additional vaccine for the moment, because 30% of the doses that were circulating, that was shipped in Africa, has not been used yet. And some of them are under a risk to expire. Actually, it is more a priority now through the vaccine delivery partnership to support countries deliver those vaccines than to order additional vaccine. WHO is encouraging all countries that are processing vaccine to do it through the appropriate channel and also through the appropriate system in their country. And when Aspen is eligible, and I think it is a good thing to apply to order at Aspen. I don't know for the time being specific commercial effort that WHO has done in order to market Aspen product.
Thank you very much, Dr. Gay. Dr. Nixie, do you want to add, or Dr. Balde?
Not really. I think Dr. Salam has said it all, and this is a kind of complex market, definitely, and is driven by the demand and also the request. And we have some challenges at the beginning, and I think there have been some lot of effort which has been made for doing the procurement. But definitely, I think, as rightly said by Dr. Gay, we will ensure all of the necessary support, for really implementing this type of, I think, industries in Africa now and in the future. It's, I think, the pandemic has shown really the importance of having these functional industries. So we WHO, the member state, and all of the other partners are really very supportive to have this localization, of the medical industry in Africa. So either for the case of the Aspen or other cases, I think definitely all of the top management of the World Health Organization, will be quite supportive, to this exercise. Thank you, and back to you.
Thank you. Thank you very much. We're coming to the end of our meeting. I don't have at hand additional questions, so we will wind up. But before that, we'd like to turn to our panelists and to ask each of you to give us your final remarks and messages. We'll begin with Dr. Keita. Over to you.
Yeah, thank you so much. I think my final comment would be on the epidemic. So I think WHO is supporting the Ministry of Health as well as other partners such as MSF, Alima, IMC to respond quickly to this outbreak. So of course, the DRC has capacity. We know that this is not, as mentioned by Professor Placide, is not the first outbreak in this area. So I think there are still some capacities on the ground, and we are confident that we'll be able to quickly stop this outbreak. And we will need, of course, some support, because the response plan has just been approved and endorsed by the regional level, maybe by the national level. So maybe we will need also some funding to support this response. Over.
Thank you very much, Dr. Keita. Can we have Dr. Professor Mbala for comment?
Alors, oui, au fait, ce que moi je pourrais dire, c'est que je tiens d'abord à remercier au fait les organisateurs de cette conférence de presse, mais aussi particulièrement l'OMS qui continue à nous soutenir pour pouvoir continuer à lutter contre ces différentes épidémies. Et c'est grâce à cet appui OMS Africa CDC que nous avons un matériel qui permet de faire vraiment de la surveillance génomique. Et vu la grandeur du pays et vu aussi le rôle que l'INRB peut jouer sur le plan continental, nous pensons également continuer à décentraliser cette technique de surveillance génomique dans les différentes provinces de notre pays et aussi à accompagner les autres pays de la sous-région à développer également ces mêmes capacités dans ces différents pays. Voilà ce que je pourrais dire.
Merci beaucoup, Professeur Bala. Over to Dr. Nixie for your remarks. Thank you.
Is that me?
Dr. Nixie? Yes, we can hear you.
Thank you. Firstly, thanks to the WHO for highlighting the importance of environmental surveillance. A number of questions around surveillance for SARS-CoV-2 have highlighted the gaps in surveillance programs. Environmental surveillance is a relatively inexpensive modality. And we're looking forward at the NICD to working with the WHO and regional partners to strengthen environmental surveillance across the continent. Thank you.
Thank you. Dr. Nixie, please go ahead.
Thank you so much, Dr. Pinter. I don't have much to say, but as long as we are really keeping very close eyes in this virus that is keep on mutating all the time, so we're going to continue working closely with the laboratories and also with the specialists in this field to study it even further so that whatever the next pandemic is coming through, we'll be ready to deal with it. Over to me.
Thank you very much. Zora, any remarks or comments you would like to make?
Thank you very, very much. Just wanted to add that many countries are now conducting mass vaccination campaigns on the continent, and this has been seen to be a game changer in countries such as Uganda, Ethiopia, Cote d'Ivoire, Sierra Leone, Zambia, and Chad, and even Guinea. They have recorded their highest increase in population coverage in the last 2.5 months for COVID-19 vaccination. And as WHO, we are supporting countries in 20 high priority countries that are countries that are whose coverage is below 10% for COVID-19 vaccine. And this is supposed to help address bottlenecks in operations and unlock funding. Just to add that the issues that we are fighting against in the continent are issues around low risk perception of COVID-19, especially now that the cases and the deaths have been on the decrease. And now countries are running awareness campaigns for people to return for their second dose and also to get their first doses. And all these campaigns are also helping to address concerns about the vaccines and increase vaccination uptake. Thank you, Binta. Over.
Thank you very much, Dr. Balde, and then Dr. Gay, before we go on to a small session in French. Over to you, Dr. Chamabalde. Or perhaps if Dr. Balde is not available, or Dr. Gay, for last remarks before we go on to the French session, short French session.
Very short remark, just to thank all the panelists who contributed to this exchange with the journalists, but also to really try to advocate for more testing. Many countries are testing less, and it makes us a little bit blind on knowing exactly what are the situation. The surveillance systems will be revamped, and so we will be able to detect what's happening and get ready before it creates additional suffering and death in our countries. In South Africa, the number of cases are increasing. We know that the fourth wave started like that. It may be good that we get ready, all of us, and also to put in place a system that will help earlier detection and better response for COVID-19. And thank you very much, everybody who follow us during this press conference.
Thank you very much to all of you. And now we'll open the floor to the Francophone reporters that would like to ask their questions. Are there any questions for the Francophone reporters?
Allô, bonjour à tout le monde. Binta, c'est le moment de la session francophone?
Oui, c'est ça. Nous commençons la session francophone. Merci beaucoup. On a remercié les panélistes et on a une petite session francophone.
Merci à vous tous. Docteur Keita, êtes-vous en ligne?
Oui, je suis là, je suis en ligne.
Et Docteur Baldé? OK. Docteur Keita, vous pouvez nous faire un petit point, s'il vous plaît, en français sur la situation d'Ebola en RDC, s'il vous plaît?
Oui, rapidement, hein, je disais que la situation, la tendance globale de cette épidémie en cours en RDC est pour le moment relativement encourageant. Alors, nous avons, depuis la déclaration de l'épidémie le 23 avril, rapporté 3 cas confirmés. Malheureusement, ces 3 cas sont déjà décédés. Notre dernier cas a été rapporté le 4 mai, ce qui fait qu'aujourd'hui, on a quand même dépassé 7 jours consécutifs sans aucun cas. Alors, ce n'est pas tout à fait dire que l'épidémie est en train de se terminer, non, mais c'est quand même un signe un peu encourageant quand on le compare aux épidémies précédentes. Cependant, nous avons encore environ 480 contacts qui sont en cours d'être suivis, mais juste mentionner que 200 d'entre eux vont sortir, donc vont compléter aujourd'hui leur suivi aujourd'hui, et donc à partir de demain, le nombre de contacts va également diminuer. Alors, toutes les piliers de réponse sont déjà fonctionnels, vraiment en train de travailler sur le terrain. Et nous avons du vaccin qui est sur place. Nous avons également le traitement spécifique qui est également sur place, avec bien sûr l'appui de l'INRB et professeur Placide qui est là dans l'appel. Et donc, mais aussi, nous sommes en train aussi de s'activer pour renforcer la surveillance autour des zones qui sont en périphérie de Mbandaka pour se rassurer effectivement qu'il n'y a pas de problème. Donc, le système d'alerte est en train d'être renforcé dans toutes ces zones afin d'être sûr qu'effectivement, il n'y ait pas de problème. Donc, vu tous ces éléments, le nombre de cas et le nombre d'alertes qui est quand même en train d'augmenter petit à petit, nous pouvons dire que la tendance est encourageante et peut-être avec un peu de chance, on pourra être capable d'arrêter cette épidémie très rapidement. À vous.
Merci, Dr. Keita. Une autre question par rapport au fait que la propagation a l'air d'être limitée en Mbandaka, mais est-ce qu'il y aurait un risque pour les villes environnantes? À vous?
Oui, en fait, le risque, une épidémie d'Ebola, quand ça survient dans une grande ville, le risque est toujours là, ça il faut le dire. Alors, Mbandaka est une grande ville, globalement une ville d'environ 1 million d'habitants. Et donc, et aussi, cette ville a une connexion non seulement par des aéroports, mais aussi une connexion avec le fleuve. N'oubliez pas que le fleuve Congo passe par la ville de Manaka, et donc ce fleuve-là, d'ailleurs, le lie jusqu'à Kinshasa, ça descend jusqu'à Kinshasa, et aussi il y a des routes qui lient Mbandaka à d'autres villes, mais aussi des aéroports. Donc il y a des vols qui quittent Mbandaka pour Kinshasa, pour d'autres régions. Donc tout ceci fait que le risque, il est là. Donc c'est d'ailleurs ce qui fait que dans l'évaluation initiale qui a été faite par l'OMS, on a estimé le risque élevé au niveau national, modéré au niveau régional et bas au niveau mondial. Alors, tant qu'une épidémie est encore en cours, le risque, pour le moment, il est là. Et donc, avec la tendance en cours, on peut dire que peut-être dans quelques semaines, on pourra réévaluer ce risque-là. Mais nous n'avons pas encore pu identifier clairement, je dis bien clairement, la source de la contamination du premier cas, ce qui fait qu'il y a aussi des éléments sur lesquels on peut dire, bon, on n'a pas encore peut-être toute la maîtrise donc toutes les pièces du puzzle, donc il y a aussi un risque qui est là. Donc ce qui fait qu'on peut dire, effectivement, le risque demeure encore, mais nous pensons qu'avec les capacités qui sont sur place, nous pouvons contrôler rapidement cette épidémie. Merci à vous.
Merci, Dr Keita. Dr Salam a bien voulu se prêter aux questions des francophones. Dr Salam, vous nous entendez?
Oui, je vous entends bien, très bien.
Merci. Donc, il y a une question d'ordre général de Alphonse Logo de l'agence Anadolu. Il voudrait savoir en fait où est-ce qu'on en est aujourd'hui après 2 ans de combat acharné pour la survie de l'humanité. Est-ce qu'on a réellement vaincu la COVID, vu qu'il semble qu'on ne parle plus beaucoup de la COVID dans certains milieux? Pensez-vous que maintenant, on peut se reposer ou qu'est-ce que vous en pensez?
Je sais que la lutte que tout le monde a effectuée contre la COVID a résulté sur des millions de vies qui ont été sauvées, à notre avis et selon certaines estimations. WHO va publier aujourd'hui ou bien demain la stratégie pour la phase suivante de la lutte contre COVID. Dr Mike Ryan, qui est notre directeur exécutif, a présenté qu'il y a 3 possibilités pour la suite. La première possibilité, qui est plus probable, est qu'il y ait des variants qui continuent à venir de façon saisonnière et que ces variants demeurent à des infectiosités et à des virulences qui sont vraiment comparables à Omicron ou bien d'autres variants qu'on connaît actuellement. Ce qui signifie que COVID va rester encore peut-être plusieurs années avec une saisonnalité et qui a besoin de certaines vaccinations pour une population déterminée. La deuxième possibilité est qu'il arrive des variants de moins en moins virulents et qu'à un certain moment, la population va développer une immunité qui fait que la vaccination n'est pas possible, n'est pas nécessaire, mais quand même, il y a quelques cas plus ou moins exceptionnels de gravité. Dans ce cadre-là, on va rester aussi continuer à vivre avec COVID-19. Dernier scénario est que c'est le scénario qui est le scénario malheureusement qui est le moins favorable, où il y a l'apparition de variantes qui sont de plus en plus virulentes. Et dans ce cadre-là, la lutte va continuer et aussi, malheureusement, certaines vies et beaucoup plus de vies vont aussi être perdues à cause de COVID-19. Donc, de façon générale, nous avons jusqu'à présent, comme une communauté, lutté contre COVID. Et il faut qu'on continue la surveillance. Il faut aussi qu'on continue les mesures de santé publique et sociale, notamment en se lavant les mains, porter des masques et surtout, se faire vacciner. Quand il n'est pas possible de vacciner tout le monde, au moins de vacciner les personnes les plus vulnérables.
Merci, Dr Gay. Monsieur Logo, toujours, il voudrait savoir quel est le degré de propagation sur le continent des nouveaux variants de COVID-19 qui circulent actuellement en Afrique du Sud. À vous, Dr Gay.
Oui, les variants qui circulent dans le monde, actuellement, c'est Omicron dans sa variante BA2 qui est le plus prédominant. Mais en Afrique, on a presque beaucoup de variants, notamment BA1, BA2 et BA4 et BA5. Ces variants les plus fréquents en Afrique du Sud, c'est BA4 et BA5 qui sont actuellement en train de créer une 5e vague en Afrique du Sud. Quand on connaît toutes les relations qui existent dans les pays sud-africains, notamment Angola, Mozambique, Zimbabwe, Botswana, Zambie, qui ont des frontières et aussi des relations économiques très étroites avec l'Afrique du Sud, il y a des possibilités que ça se propage dans ces pays dans un premier temps, mais aussi que cela passe aux pays de l'Afrique centrale et de l'Afrique de l'Est et de l'Ouest. Donc, la possibilité que ces variants en Afrique du Sud soient propagés au reste du continent est réel. Et à l'OMS, nous sommes en train de travailler avec les différents gouvernements pour qu'ils puissent améliorer leurs conditions de détection et aussi de réponse, notamment au niveau communautaire, mais aussi au niveau des services d'urgence pour les cas graves et surtout aussi, notamment en développant la vaccination chez les personnes vulnérables.
Merci, Dr. Gay. Par rapport à Ebola, Dr. Mori Keita, tout à l'heure, je n'ai pas mentionné, mais le journaliste, c'était M. Prince Yassa de Congo Croissance qui avait posé la question sur Ebola. Une question sur Ebola, Dr. Keita. On voudrait savoir, est-ce que l'OMS interdit la consommation de la viande de brousse pour éviter la chaîne de transmission de l'animal à l'homme? À vous, Dr. Keita.
Bon, j'ai mon directeur qui est dans le call, donc peut-être qu'il va répondre à cela. Mais en fait, je pense qu'il faut d'abord clarifier, hein, c'est ce que j'ai dit tout de suite dans la session anglaise. D'abord, pour comprendre que Ebola ne peut pas résister devant certains agents physiques comme la chaleur. Donc, ce n'est pas la viande de brousse qui est comme telle le problème, mais c'est les conditions de préparation. Parce que une viande qui est préparée à 80 degrés et pendant 30 minutes, le virus n'existe plus là. Donc ça, il faut quand même qu'on le mentionne. Donc, mais comment cette viande est préparée, et les conditions ou bien manipulées, c'est cela qu'il faut focaliser la communication. Alors, je le disais encore, hein, c'est très bien quand on est dans les grandes capitales de penser que, bon, on devrait interdire la consommation de la viande de brousse, mais dans une ville, dans la forêt équatoriale ici, où des gens qui vivent uniquement de chasse, ça va être difficile de leur dire, bon, ne mangez pas la viande. Alors, je pense que le mieux, c'est de leur dire ce qu'il faut faire avec la viande de brousse. Donc, c'est-à-dire bien préparer avec la chaleur pour se rassurer effectivement que le virus est complètement éliminé là-dedans. Par contre, je pense aussi qu'il faudrait qu'on voie comment renforcer au niveau communautaire des plateformes communautaires One Health, ça se fait déjà dans certains pays, pour qu'il y ait vraiment des agents impliqués dans la surveillance de la forêt avec les agents de santé, qu'ils puissent travailler ensemble jusqu'au niveau communautaire pour communiquer sur les risques. Parce que les gens ont besoin qu'on communique sur le risque pour leur dire ce qu'il faut, ce qu'il ne faut pas faire. Mais il faut aller sur des évidences. Parce que si on dit aux gens de ne pas manger la viande de brousse, on sait que ça, c'est impossible. Ils vont le manger. Donc, on ne va pas concentrer le message sur ça. Alors, disons-nous, qu'est-ce qu'il faut, quand vous avez la viande de brousse, ce qu'il faut faire, c'est de le cuire très bien, à une température aussi élevée pendant tel temps pour que le virus puisse être complètement éliminé. Donc, mais aussi, la surveillance à base communautaire, rapporter les événements. Parce que souvent, avant même que le virus ne quitte l'animal à l'homme, il y a aussi, on l'a vu dans même d'autres pathologies, qu'il peut y avoir des morts d'animaux, peut-être des chauves-souris qui meurent ou des animaux qui meurent. Donc, tout ceci, on doit avoir ce mécanisme au niveau communautaire pour dire que quand vous voyez des animaux qui meurent d'eux-mêmes, je pense que c'est un problème. Parce que c'est différent quand on cherche, c'est-à-dire qu'on est allé chercher un animal, là, c'est un animal peut-être qui était vivant, bien portant, qui a été chassé. Mais des animaux qui meurent d'eux-mêmes, donc vous voyez, en faisant cette différenciation, je pense qu'on peut amener certainement ces communautés à prendre plus de précautions, mais ce sont juste quelques éléments, mais je pense que mon directeur, qui est aussi un expert de ce domaine, peut apporter des éléments de communication ou de clarification sur cette question-là. Je pense que Dr Salam pourrait peut-être compléter là-dessus.
Merci, Dr Keita. Dr Salam, à vous et pour la conclusion aussi, s'il vous plaît. Merci, Dr Guy.
Très rapidement, l'OMS n'interdit pas la consommation de viande de brousse. Actuellement, le risque de Ebola est vraiment divers. Il y a les survivants. On a des milliers de survivants à Ebola. Et malheureusement, le virus a trouvé un sanctuaire dans le corps humain où cela peut rester des mois, voire même des années. Les chauves-souris aussi ont été déclarés comme des réservoirs de virus qui peuvent avoir le virus sans tomber malade. La plupart des animaux qui sont mangés par l'être humain ne résistent pas à Ebola. Donc, quand ils ont Ebola, ils tombent malades et meurent, ce qui fait que souvent, c'est connu. Et comme Dr Mori l'a dit aussi, la cuisson qui est faite actuellement souvent en Afrique permet d'éliminer le virus. C'est souvent l'une des interactions avec les animaux où il y a probablement beaucoup de problèmes en ce qui concerne Ebola, mais aussi en ce qui concerne beaucoup d'autres maladies et très probablement aussi COVID-19. C'est pourquoi l'OMS avec FAO, OIE et d'autres organisations sont en train de travailler sur une seule santé qui permet de faire une collaboration beaucoup plus étroite et aussi d'aborder les problèmes de santé publique en commun avec nos collègues de l'agriculture, de l'environnement, pour qu'on puisse détecter de façon très précoce et répondre aux maladies qui touchent en même temps la nature, les animaux et les êtres humains. J'en profite aussi pour faire une remarque d'ordre général pour clôturer. La pandémie de COVID-19 actuellement est un peu à un niveau bas dans le reste du monde où ça diminue régulièrement. En Afrique, ça augmente, mais c'est particulièrement au niveau de la partie sud-australe de l'Afrique où il y a une augmentation récente durant les dernières semaines. Au niveau est et central, il y a une réduction très importante même de jusqu'à 80%. Au niveau de l'Ouest, il y a une réduction d'environ 8% et au niveau de l'Afrique du Nord aussi. Mais je pense que cela peut ne pas vraiment dire la réalité parce que le nombre de tests a baissé considérablement dans beaucoup de pays. Aussi, on doit rester vigilant à cause de cette augmentation qui a commencé en Afrique du Sud, parce que c'est comme ça que la 4e vague avait commencé. De l'Afrique du Sud, c'est passé au niveau de l'Afrique centrale et de l'Est et finalement au niveau de l'Afrique de l'Ouest. Tous les pays doivent continuer à développer leur système de surveillance et surtout que ça comprend aussi la surveillance et la prise en charge domiciliaire, qui est un élément de la surveillance communautaire. Il faut aussi qu'ils développent leur capacité de soins urgents et de voir la disponibilité de l'oxygène, mais aussi la fonctionnalité des usines d'oxygène qui ont été déjà installées dans ces pays. Que tout soit testé, cela peut ne pas signifier grand-chose, mais il vaut mieux être prêt que le regretter dans le futur. Merci beaucoup tout le monde.
Merci à tous d'être restés, chers francophones. Merci et à la semaine prochaine. Merci Dr Gay, Dr Keita. Au revoir à tout le monde.
Merci, au revoir.